Assalamualaikum dear students. I'm Dr. Neelofar Yousaf from Department of Pharmacology, and today our topic of discussion is immunosuppressants. Learning objectives of our today's lecture are: by the end of lecture, students should be able to describe the features of cell-mediated and humoral immunity, classify immunosuppressive agents. They should be knowing how to describe the mechanism of action, clinical uses, and adverse effects of major immunosuppressive agents, including antibodies and corticosteroids. So, starting our lecture with the name of Allah, let's see what is immune system and how it plays its important role in our body. The immune system plays an important role in protecting the body against harmful foreign molecules. Immune system protection can result in serious problems. For example, if there is transplantation done in our body of some specific tissue cell, it may get rejected. Then, immune system also can lead to various autoimmune diseases. The introduction of an allograft can elicit a damaging immune response, thus causing rejection of the transplanted tissue. However, transplantation is one of the important treatments. Drugs can selectively inhibit rejection of transplanted tissues while preventing the patient from becoming immunologically compromised. So, immunosuppressive therapy alters lymphocyte function using drugs or antibodies against immune proteins. Immunosuppressive therapy is used in the treatment of autoimmune diseases too, such as corticosteroids are used to control acute glomerulonephritis. Immunosuppressive drug regimens usually consist of 2 to 4 agents. As we know, it is not an easy task to do the treatment with different mechanism of action that disrupt various levels of T cell activation. Immunosuppressive drugs can be categorized according to their mechanism of action. So, agents that interfere with cytokine production or action, then there are agents that disrupt cell metabolism, preventing lymphocyte proliferation, and there are antibodies that block T cell surface molecules. Let's have a look at the classification. Selective, you should learn classifications from Sir Said's notes. Selective inhibitors of cytokine production function such as Cyclosporine, Tacrolimus, Sirolimus, Everolimus. Then comes immunosuppressive antimetabolites. Then comes antibodies, corticosteroids, and anti-TNF alpha agents. Let's discuss cyclosporine. It acts through making complex of cyclosporine with cyclophilin and inhibits calcineurin. What they do after making the complex in inhibiting calcineurin, this suppresses cell-mediated immune reactions. This leads to a decrease in interleukin 2, which is primary chemical stimulus for increasing the number of T lymphocytes. Cyclosporine may be given either orally or by IV infusions. Its various uses are to prevent rejection of kidney, liver, and cardiac allogenic transplants. They are combined with corticosteroids and antimetabolites such as mycophenolate, mofetil. I told you in the start that combination of 2 or more drugs is given for immunosuppressive therapy. So they are used as alternative to methotrexate for the treatment of severe active rheumatoid arthritis. They are used in recalcitrant psoriasis that does not respond to other therapies and xerophthalmia. Adverse effects are nephrotoxicity, hepatotoxicity, lymphoma, anaphylactic reactions, hypertension, hyperlipidemia, hyperkalemia, tremors, hirsutism, glucose intolerance, and gum hyperplasia. Then our next drug is tacrolimus. This is approved for the prevention of rejection of liver and kidney transplants. They are given in combination with corticosteroid or with antimetabolite. They gain favor over cyclosporine. They are preferred over cyclosporine because its potency in decreased episodes of rejection and low doses, and they are used in low doses of corticosteroids. They are administered orally or intravascularly. They causes a decrease in interleukin-2. Adverse effects are nephrotoxicity, neurotoxicity, post-transplant insulin-dependent diabetes mellitus, anaphylactoid reactions to the injection. Then our drug comes Sirolimus. It is approved in renal transplantation. It can be used together with cyclosporine and corticosteroids, allowing lower doses of those medications to be used. The combination of sirolimus and cyclosporine is synergistic. That means it enhances the our required desired therapeutic effect. Drug is available as an oral solution or then immunosuppressive antimetabolites such as azathioprine, mycophenolate, mofetil. Azathioprine, a prodrug that is converted first to 6-mercaptopurine and then to nucleotide thioinosinic acid. Its rapid proliferation is important for the immune response, which depends upon the de novo synthesis of purines required for cell division for lymphocyte in particular. The adverse effects are bone marrow suppression. Then comes mycophenolate mofetil. It is a purine antagonist. It is used in heart, kidney, and liver transplants. It is rapidly hydrolyzed in the GI tract to mycophenolic acid, which is a potent inhibitor of iosine monophosphate dehydrogenase, which blocks the formation of guanosine phosphate. It deprives the rapid proliferating T and B cells, which is a key component of nucleic acid. Adverse effects are diarrhea, nausea, vomiting, abdominal pain, leukopenia, and anemia. In an effort to minimize the GI effects associated with mycophenolate, mofetil, enteric-coated mycophenolate, sodium is contained within a delayed release formation. That means slowly it releases and it decreases the adverse effect related to GIT. Then comes antibodies. They are prepared by immunization of either rabbits or horses with human lymphoid cells by producing a mixture of polyclonal antibodies or monoclonal antibodies. And there's another way too. They are prepared by hybridoma technology. That is, by producing antigen-specific monoclonal antibodies. Hybridomas are produced by fusing mouse antibody. Then comes anti-thymocyte globulins. Anti-thymocyte globulins are polyclonal antibodies that are primarily used at the time of transplantation to prevent early allograft rejection along with other immunosuppressive agents. The antibodies bind to the surface of circulating T lymphocytes. Then the antibody-bound cells are phagocytosed in the liver and spleen, resulting in lymphopenia and impaired T cell responses. ठीक है जी. तो ये जो antibodies are slowly infused intravenously and their half-life extends from 3 to 9 days. Then comes Muromonab CD3. It is a murine, meaning its origin is from mouse. It is extracted from mouse monoclonal antibody that is directly against the glycoprotein CD3 antigen of human T cells. It is indicated for the treatment of corticosteroid resistant acute rejection of kidney, heart, and liver allografts. Then comes Basiliximab. 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 ठीक है जी. It is an interleukin-2 antagonist. It is chimerized, meaning it consists of 25% of murine from mouse and 17.5% of human protein. It is approved for the prophylaxis of acute rejection in renal transplantation in combination with cyclosporine and corticosteroids. It is not used for treatment of ongoing rejection. They bind to interleukin-2 receptor and activated T cells interfere with proliferation of these cells. We give it via IV infusion, and this drug is generally well tolerated with GI toxicity as the main adverse effect. Whereas autoimmune conditions, refractory rheumatoid arthritis, systemic lupus erythematosus, and asthma, prednisone are the exact mechanism responsible for immunosuppressive action of the corticosteroids is unclear, whereas T lymphocytes are mostly affected. They reduce lymphocyte populations by lysis or redistribution. On entering cells, they bind to the glucocorticoid receptor. The complex passes into the nucleus and regulates the translation of. So, this was our today's lecture. It was very compact, small lecture. Try to listen it again and again. And if there is any kind of confusion, you people are more than ask me on a WhatsApp group. So now I'm going to give you today's assignment, which is classify immunosuppressive agents. You people have to submit this assignment before the finishing or time of your lecture. ठीक है जी? That is, I guess, 10:45. So hurry up, listen to the lecture again, and complete your assignment and submit it. Thank you. Allah Hafiz.